Hi, welcome to our channel of IGNOU audiobooks. Indira Gandhi National Open University, School of Health Sciences, SOHS, Diploma Programs. Postgraduate Diploma in Maternal and Child Health, PGDMCH. MME-201 Preventive MCH. Block-1 Basics of Prevention. Unit-1 Rationale and Goals of MCH Care. 1.0 Objectives. In this unit, you will learn about the reasons for the emphasis on maternal and child health. MCH, care as a distinct entity in health care delivery, some ideas on the extent of various health and nutrition problems in children and mothers, and briefly the items that constitute what is known as the package of services under MCH care. After going through this unit, you should be able to describe briefly how the MCH care in India has progressed over the years. Understand why mothers and children are regarded as single unit for preventive care. List the problems requiring attention amongst children and adolescents. List the problems requiring attention amongst women in the reproductive age. Describe the concept of at-risk approach and list the components of the MCH care package for children and women. 1.1 Introduction. During the course of your graduation studies, you must have learnt various aspects of family medicine during your postings in the rural and urban health centers. At that time, you were participating in the implementation of various components of the national health programs as applicable to your state or union territory. In this unit, you will relate the components of the national health programs as they apply to individuals and families in the community and the various preventable health and nutrition problems that are known to occur in our country. You will also learn about the reasons for the special emphasis on MCH and also why it is very practical and useful to consider the mother and child as one single unit. You will also learn briefly the difference in approaches while rendering care to children and women in the reproductive age group. The purpose of this unit is essentially to help you in appreciating the objectives of such an integrated preventive and holistic approach to MCH care. 1 point to brief history of MCH care. Let us review in brief the progress of MCH care over a period of time. Manu Sanhita is possibly the older description of MCH care as it prescribes not only rules and regulation for personal health but also the dietetics and hygienic rituals at the time of birth and death. The first Vaccination Act was passed in 1880, and it took nearly 95 years before India became free from smallpox. The first Maternity and Child Welfare Bureau was established under the Indian Red Cross Society in 1931. The Health Survey and Development Committee, Bhure Committee, was appointed in 1943 and it submitted its wide-ranging recommendations in 1946. The report of the committee, in many ways, formed the basis for the development of the public health structure and services in the country. The concept of Primary Health Center, PHC, was introduced in the Bhure Committee Report, 1946 as being the basic health unit to provide, as close to the people as possible, an integrated curative and preventive health care to the rural population with emphasis on preventive and promotive aspects of health care. A nationwide family planning program was launched in 1953 with the objective of controlling the population explosion. In 1978, the Alma-Ata International Conference on Primary Health Care reaffirmed health for all as the major social goal of governments and stated that the best approach to achieve the goal of HFA is by providing primary health care, especially to the vast majority of underserved rural people and urban poor. Of the 8 essential elements of the primary health care, 3 functions with MCH, including family planning, immunization against major infectious diseases, and education of the community about health and nutrition have a direct bearing on the outcome of the maternal and child health-related goals and objectives. The National Health Policy was developed in 1982 on the basis of the HFA goals of Alma-Ata adopted several goals and indicators to be achieved by the year 2000, and the policy was adopted by the Indian Parliament in 1983. You will learn in detail about the policy in Unit 18, Block 5. In September 1990, an unprecedented World Summit for Children, heads of states from 79 countries and leaders from over 120 other countries committed for achieving certain goals for the survival, protection, and development of children. These goals cover a wide-ranging areas of maternal and child health and nutrition, and mechanisms have been set in programs of various countries to ensure that these goals are reached and monitored. Further, world conferences such as the International Conference on Population and Development at Cairo in 1995 identified additional goals and objectives to be attained by the year 2015. India was declared smallpox-free on 5th July, 1975, and the Scheme of Integrated Child Development Services, ICDS, was launched on a pilot basis in 33 rural, tribal, and urban blocks of the country the same year on 2nd October. The ICDS scheme since then has expanded steadily to cover the entire country by the year 1997. The expanded program on immunization was launched in 1977, and the Universal Immunization Program was launched in 1985. It envisaged strengthening of the infrastructure to maintain cold chain at various levels, along with a focused approach to immunize all undertones against the 6 vaccine preventable diseases. The national program included for the first time immunization against measles as part of its package of services. A diarrheal diseases control program was initiated in the major medical colleges of the country with the setting up of the diarrhea treatment units in the second half of the 80s. In 1990, a pilot project on acute respiratory infections control was initiated in 14 districts of the country. In 1992, the National Child Survival and Safe Motherhood (CSSM) program with major modifications on the approach to MCH care was launched, and the program has been universalized in a phased manner to cover the entire country by 1997 with further modification. The Comprehensive Reproductive and Child Health (RCH) program was initiated in 1996 and is expected to be modified to RCH2 from 2003. You will learn in detail about RCH program in Unit 9 of Block 2. At the level of the family and individual practice over a period of time, you must have noticed a steady transformation in medical practice. With the advent of specialization and super specialization, there has been an erosion of the entity general practitioner, at least in major metropolis and cities. In recent times, however, family medicine has re-emerged as a strong discipline, and a major share of family practice constitutes preventive and promotive care for maternal and child health. 1.3 Rationale of MCH care. To ensure development of any society, mothers and children constitute a priority group for a variety of interventions. In sheer numbers alone, they comprise approximately 60 to 70% of the population in any community, be it the urban ward, the village, the block, the district or state or country. In our own country, the women of the childbearing age, 15 to 44 years, constitute about 22%, and children under 15 years about 40% of total population. 1.3.1 Special nature of the group. Not only do mothers and children constitute a large group, but they are also a vulnerable or special risk group. Childbearing itself is a risk in the case of women, and in the case of children, survival, growth and development, all of them have considerable risks attached to them. Despite decades of progress in medicine and public health and an ever-increasing arsenal of weapons to prevent and treat childhood and maternal illnesses, more than 12 million children and almost 500,000 women die every year. They are responsible for almost half of the disease burden in our country. The major problems, as you know, are the communicable diseases of childhood, such as pneumonia, measles, diarrheal diseases, malaria, other vaccine-preventable infections, and intestinal parasitic infestations, malnutrition, and poor reproductive health, the consequences of unwanted pregnancy and the complications of pregnancy, childbirth, and the first week of life. Closely related to the above problems are unacceptably high mortality rates among women during reproductive years of life and children during early childhood period. The current levels of maternal mortality rate, MMR, and infant mortality rate, IMR, of 4 and 71 per thousand live births respectively, justifying the need of safe motherhood and early childhood care services. Added to it, high fertility rates make mother and children more vulnerable to diseases and deaths. You will appreciate that much of the sickness and deaths among mothers and children are preventable. By improving the health conditions of mothers and children, we can improve the health status of general population to a great extent. These considerations have led to the formulation of special health services for mothers and children, adolescent girls and women during perimenopausal age, including the services for aged women. 1.3.2 Mother and child as one unit. You will appreciate that mother and child can be considered as one unit because of following reasons. A. During the antenatal period, the fetus is an integral part of mother. It develops in the uterus and obtains the nutrition and oxygen from mother's blood. B. Health of mother and child are interrelated. Healthy mother brings forth a healthy baby. C. Mother can transmit certain diseases to the child during pregnancy such as syphilis, German measles, etc., which are likely to affect the child health. D. Breastfeeding during early childhood period is a regulator process of health. E. Primary socialization of a child is always initiated by mother. 1.3.3 MCH Problems. The main health problems affecting the health of mothers and children in our country revolve around the triad of malnutrition, infection, and the effects of unregulated fertility. Associated with these are the problems of health delivery system, socio-economic and cultural factors which will be discussed in subsequent unit. A. The problems in children. Some of the important problems affecting the health of children are low birth weights, unacceptably high mortality rate during early childhood period, poor nutritional status, high level of anemia, acute respiratory tract infections, diarrheal diseases, high level of school dropouts, child labor and abuse, social problems of adolescence, drug abuse and sexual problems, disabled children, physical, mental and also behavioral problems in street children. B. The problems in women. Some of the important problems among women in our country are early age of marriage, teenage pregnancies, unsafe abortion, unwanted fertility and infertility, high fertility rate and rising population, unacceptably high mortality rate amongst women in reproductive age group, poor nutritional status, high level of anemia, reproductive tract infections, sexually transmitted diseases and emerging problem of HIV/AIDS, unfavorable sex ratio, gender discrimination, low level of literacy amongst females, low status of women and heavy workload and violence against women. C. Problems of adolescent. Problem of adolescent girl. 1.3.4 At-risk approach for MCH. The risk assessment approach in antenatal care has low predictive value for maternal Mortality. Modality of antenatal care could reduce 11% of maternal mortality. At risk. Approach may not be the best approach to reduce maternal mortality, as data of maternal mortality revealed that over 50% of women who were not considered as at-risk mothers experienced maternal mortality. Therefore, universal essential care for all pregnant mothers is envisaged. All pregnant women are at risk from obstetric complication. Danger signs during pregnancy, labor, delivery, childbirth, and postnatal period must be recognized at the earliest at home by mother or family, at health facility, and right decision taken to refer the mother to a nearby facility for quality management of obstetric complications without losing time. Delay can kill. Delay in decision making in case of complication, delay in reaching the health facility, and delay in receiving proper treatment can endanger lives of mothers and children. Emphasis on antenatal care for risk detection at the primary care levels leads to either denial or non-utilization of obstetric services in the review of complications. Risk detection leads to expectation that primary health care workers will always be able to deal with the low-risk pregnancy. It is when these supposedly low-risk pregnancies encounter unexpected complications, or when the high-risk pregnancies do not encounter complications, the credibility of healthcare worker is lost. The first and foremost requirement is to enable women and their families to realize that all pregnancies are at risk and recognize early complications. This does not necessarily require more antenatal care, risk detection, or training of traditional birth attendants, TBA, on the pattern of past decades. Reorientations of what is done in currently conducted antenatal care, earlier detection of actual problems, and training TBA to recognize women with complication and ensuring referral immediately to appropriate level of care is required. 1. 4. MCH Care Package. You must be familiar with package of health care for mothers, which includes identification and registration of all pregnant women, provision of quality antenatal care, immunization of all mothers with tetanus toxoid, detection and management of complicated pregnancy, including hypertension, APH, PPH, CPD, and sepsis. It is of utmost importance to impart effective communication to adopt right age for marriage, ideal age for reproduction, and small family norm. Through your experience, you must be knowing that package for child healthcare services includes care of newborn at home, immunization, home management of pneumonia, management of diarrheal diseases, wheat, a prophylaxis, prevention of iron deficiency, anemia, and iodine deficiency disorders. 1.4.1 MCH Care for mothers. The aim of maternal care is to ensure that throughout the pregnancy and puerperium, the mother will have good health and that every pregnancy culminates in a healthy mother and healthy baby. For this, following services need to be provided. Pregnant women. Essential care for all. Register by 12 to 16 weeks. Antenatal checkup at least 3 times during pregnancy. The purpose of antenatal checkup is to monitor progress of the pregnancy and to identify and refer high-risk cases for appropriate treatment at hospital. Tetanus toxoid immunization should be given to all pregnant women as early as possible during pregnancy with 2 doses at 1 month interval. If already immunized during the previous pregnancy, she should receive 1 dose of TT. Give 1 large tablet of iron and folic acid, IFA, daily for 100 days to all pregnant women. Treat those with clinical signs of anemia with 2 of IFA, large tablets daily for 100 days. Deworm with mebendazole, during to ND3 RD trimester in areas where hookworm infestation is common. Ensure safe and clean delivery services. Prepare the woman for exclusive breastfeeding and timely weaning. Postnatal care, including advice and services for limiting and spacing births. Early detection of complications. Clinical examination to detect anemia, since it is not only a major cause for maternal mortality and morbidity but is also major contributory factor for birth of a low birth weight baby. If there is bleeding before delivery, APH, and excessive bleeding after delivery, PPH, she should be referred to the nearest referral unit by the quickest mode of transport. Weight gain of more than 3 kilograms in a month or systolic blood pressure of 140 milligrams or more should arouse suspicion of preeclampsia. Such cases may also get fits, eclampsia. All these cases are medical emergencies and should be referred to the nearest referral unit. Body temperature of 39 degrees Celsius and above after delivery or after abortion are normally due to infections and sometimes can be fatal. They would also require treatment at the hospital. Prolonged or obstructed labor pain for more than 12 hours, can lead to rupture of the uterus. It is, therefore, essential to take them to the nearest hospital where facilities for cesarean section are available. Emergency care for those who need it. Early identification of obstetric emergencies and danger signals by mothers themselves or by health workers or by health professionals. Provide initial management and refer to identified referral hospitals. Minimum time should be wasted as delay can be fatal. Use fastest available mode of transport. You must know the hospital where such cases can be treated and properly guide the attendants so that they can shift the patient by quickest mode of transport locally available by taking shortest route. While transporting such cases, the patient should lie on her left side. In case the patient has fits, a roll of cloth should be placed between teeth to avoid tongue bite. Provide standard and quality management services for obstetric emergencies. Women in the reproductive age group. Counseling on importance of care of girl child. Optimal timing and spacing of birth. Small family norms. Use and choice of contraceptives. Prevention of RTI STD. Information on availability of MTB services. IUD and sterilization services. Provide family planning services. Condom distribution. Oral contraceptives. IUD. Prevention and treatment of reproductive tract infections and sexually transmitted diseases. Provision of clean and safe delivery practices at the community level. Create awareness in the community on need for 5 clean and safe deliveries. Deliveries by trained personnels. Provision of disposable delivery kits, DDKs, to all pregnant women. Promotion of institutional deliveries. Identification and referral of high-risk cases at the community level by trained days. 1.4.2 MCH care for children. The aim of child care services is to prevent diseases and promote physical, mental and social well-being of children so that each child may achieve the genetic potential with which he/she is born. The package of child care services includes newborn care. Take birth weight of all newborns. Normal birth weight is above 2,500 grams. Babies whose weight is between 2,000 to 2,500 gms would require special care. Such babies are to be covered well with cloths and put close to the mothers, breastfed well, and to not be handled by too many people in order to prevent infections. If the birth weight is less than 2,000 grams, the newborn must be referred for further examination and management. Resuscitation of asphyxiated babies, the mucus trapped in the mouth to be gently sucked with the help of a mucus sucker, and give mouth-to-mouth respiration if necessary. Prevention of hypothermia. Newborns are susceptible to catch cold. After birth, the newborn to be wiped dry and covered well with soft clean cotton cloth which has been washed with soap and dried in sun. Exclusive breastfeeding within 1 hour of delivery. It is essential that the newborn is given the first milk as it contains many essential nutrients and helps in developing immunity against diseases. The infant should be breastfed exclusively and no other fluid need to be given till the age of 4 to 6 months. From 4 to 6 months, semi-solid food should also be given. Referral of newborns who show signs of illness. Advise the mother on essential newborn care, prevention of hypothermia and infections, nutrition, breastfeeding and weaning, immunization, vitamin A and early signs when to seek help. Immunization. BCG, 1 dose at birth. DPT asterisk, 3 dose, beginning at 6 weeks at monthly interval. Polio, 0 dose at birth for all institutional deliveries. 3 dose beginning at 6 weeks at monthly interval. Measles, 1 dose at completion of 9 months of age. Vitamin A, first dose, 100,000 IU with measles vaccination. Asterisk, some states like Delhi have introduced hepatitis B vaccine in the immunization schedule along with DPT vaccine. Children, 1 to 3 years. DPT OPV booster dose at 16 to 18 months. Wheat. A, second dose, 200,000 IU, at 16 to 18 months along with DPT OPV booster. Third to fifth doses, 200,000 IU each, at 6 monthly interval. Children, 1 to 5 years. IFA, small tablets if child has clinical signs of anemia. Treatment for hookworm infestation if suspected. School immunization. DT at age 5 years, 1st standard. TT at 10 year, 6th standard, and at 16 year, 11th standard. Prevention of deaths due to diarrheal diseases. Correct case management for all cases of diarrheal. Early initiation of cotrimoxazole to children with signs of pneumonia. Referral of children with severe pneumonia or very severe illness. Maternal and child health. The package of services. I, for the mothers. TT immunization. Prevention and treatment of anemia. Antenatal care and early identification of maternal complications. Deliveries by trained personnel. Promotion of institutional deliveries. Management of obstetric emergencies. Birth spacing. 2. For the children. Essential newborn care. Exclusive breastfeeding and weaning. Immunization. Appropriate management of diarrhea. Appropriate management of RE. Vitamin A prophylaxis. Treatment of anemia. 3. For eligible couples. Prevention of pregnancy. Safe abortion. 4. RTI STD. Prevention and treatment of reproductive tract infection and sexually transmitted diseases. We, Adolescent Health, refer to Unit 5 of this block. 1.5 Goals and Objectives of MCH Care. The main goal of MCH care is to provide comprehensive, promotive, preventive, curative, and rehabilitative services for mother and children so that they attain a high level of health. It includes sub-areas of maternal health, child health, family planning, school health, handicapped children, adolescents, and health aspects of care of children in special settings such as daycare. The specific objectives of MCH care are reduction of maternal, perinatal, infant and childhood mortality and morbidity, promotion of reproductive health, and promotion of the physical and psychological development of the child and adolescent within the family. As mentioned earlier, the National Health Policy was approved by Parliament in 1983 and it laid a considerable stress on mother and child health activities through the primary health care approach. In the context of health for all by the year 2000 AD, the National Health Policy has suggested the following goals related MCH care in quantifiable terms to be achieved by 2000 AD. Subsequently, National Population Policy adopted in the year 2000 has specified the goals to be achieved by the year 2010. 1.6 Summary. In this unit you have learnt that the mother and children not only constitute a large group, but they are also a vulnerable or special risk group. The risk is connected with childbearing in the case of women, and growth, development, and survival in the case of infants and children. From commonly accepted indices, it is evident that infant, child, and maternal mortality rates are high in our country as compared to developed countries. You also learned that the problems affecting the health of mother and child are multifactorial. And despite current efforts, the health of mother and child still constitutes one of the most serious problems affecting the communities. In the past, maternal and child health services were rather fragmented and provided piecemeal personal health services by different agencies in different ways and in separate clinics. The present strategy is to provide mother and child health services as an integrated package of essential health care, also known as primary health care. In providing these services, specialists of different disciplines such as obstetrics, pediatrics, and preventive and social medicine have joined hands and are now looking beyond the four walls of hospitals into the community to meet the total health needs of mothers and children.